So, good morning, everybody. Welcome again in our third day of the Mediterranean Dental Meeting, MDM 2021. Yesterday, we had amazing presentations with many speakers from different countries, and today also is going to be a very interesting day because we have many speakers from different countries with different topics in the field of implant dentistry and also in another aspects of dentistry. This morning, I have a special guest from Syria. He is Dr. Imad Saloom, a specialist oral maxillofacial surgery and implantologist. We already hosted Dr. Imad 2 or 3 times, and you all comment that you enjoyed his presentation. So now I will let you all with Dr. Imad Saloom. Dr. Imad, welcome.
Thank you, Dr. Ali. Good morning to everybody. Good morning to all colleagues around the world. It's really a great pleasure for me to be hosted again at your amazing conference.
Thank you, Dr. Imad. The screen is yours. You can start.
Thank you so much, Dr. Ali. Okay, so I'll start not to lose time. This is my third time to be hosted at your amazing conference, the Mediterranean Dental Society, and it's a great opportunity to be back again with you to share with you my topic today about 20 years retrospective review of complications and mistakes that I faced in immediate implantation. Actually, this presentation will form as a cutting edge between complications versus mistakes in immediate implantation. As we all know that immediate implantation started as early as the late 70s with Dr. Schulte, where he placed a 2 ceramic implant, 2 root-form ceramic implants, and they were called at that time the Frialet 1 implant. The only disadvantage was its ability to be fractured, but those implants survived for a very, very long time. Of course, at that time, Schulte and his co-workers emphasized that the entire cross-section should be filling the whole implant or the whole alveolar site. Therefore, we have to use an implant design that mimics exactly the shape of a natural tooth root, such as the design that he mentioned in Frialet 1. Then the same companies made special other designs from titanium in a way that the entire cross-section of the socket, mainly in the cervical region, must be occupied by the implant. And this means that necessity of using a wider cervical implant diameter with a tapered shape that will offer the most possibility of obliteration of the alveolar socket, mainly at the crestal entrance. That will give a better buccal support, and they believed at that time that it may help to serve all the alveolar shape of the root prominence. Of course, other papers were published at that time in the late 80s of last century by Richard Lazara, Ramon Gomez, and Yuli Grunder, where they stated that immediate and delayed implant placement are almost similar, with the 5 years clinical experience that they had a lot of advantages with the high success rate. Of course, keeping the same rules that were mentioned also by Team Atlanta, David Garber, Maurice Salama, and Henry Salama, where to optimize success, they suggested to use a wide diameter tapered shape implant that will fill the whole socket and to fill the whole alveolar bone. All those papers also were supported by Paulo Antonio and others, where they stated that the clinical outcome and the degree of osseointegration does not make any difference between if we place the implant immediately or we make a delayed implant. And this gave a uh, very promising case to all the patients and the doctors, that immediate implantation is described not only to gain time if we place it in a fresh socket, but it will avoid, by placing immediate implantation, we will avoid the negative effect of the extraction, which we all know. In other words, that if you place immediate implantation, we will not encounter any or very minimal resorption in the alveolar process. All those all those research, the last one that I will show in 2004, showed that on a short-term survival rate and clinical outcomes, there is no difference between the immediate implantation or where we placed the implant in the totally healed alveolar ridges. All those cases, in fact, encouraged me at that time in 2003 to start my first cases of immediate implantation. As you can see here in this case, and I'm sorry for the quality of the of the photos. That was the technology 20 years ago. Well, this is one of my first early cases, and the patient came to me with the non-repairable roots. So I decided to start my immediate implantation cases. I placed my implants. I placed my implants. I placed my implants, as you can see here, and placed my healing collars. The final prosthetic work was done satisfactory, and the patient was happy. And for me, I was very happy with the result. So we gained about 4 months' time for placing the final prosthetic work. The problem started after 2 years. After 2 years follow-up, this case was this follow-up was in December 2005. That means after 2 years, the patient came back to me with the pus around the central incisor implant, as you can see, with some bone resorption. And in fact, this implant was lost after 1 year later. At that time, I started to guess what was the reason of losing this bone around this implant. According to our knowledge at that time, I went back to the Bible of implantology with the book of Dr. Carl Misch, where he stated that maybe it is the zipper effect of the vestibular bone which gives stress at the crestal bone. This may cause microfractures or overload to the labial cortex that may uh, that may result in early crestal bone loss. This is the only knowledge that we had at that time. This is another case at the same year. This one is also from my very early cases. A patient came to me with the fractured central, and I used a atraumatic extraction. As you see, I placed my implant according to the recommended protocol at that time, the early 2004. As you can see, the implant is filling the whole socket. I used a very well-known brand implant. And the final result, as you can see, the soft tissues and the contour of the soft tissues is very nice. When I place my final prosthesis, as you can see here, the prosthesis is well, but if we look at the zenith line of my final prosthetic work, you can see a kind of discrepancy between the what I had before the extraction and then a kind of resorption in the bone as well as in the soft tissues. So we had to mask this discrepancy with the pink porcelain, as you can see. Well, how about those promises that Paulo Antonio showed us at that time, that immediate implantation is described to avoid the negative effect of the extraction? In fact, we didn't at that time, and those two cases showed me that maybe there is something wrong in my technique, or there is something wrong with the whole concept. So, what was the reason? The only article that I had at that time was published by Arujo and Linda, where they described what just 1 year later after placing my implant that bone resorption and gingival recession is something which is not avoidable, even if the implants are placed at the time of extraction. So this is an unavoidable complication, what we call, or a sequence. Some of the researchers, like Becker, stated that maybe raising a flap may cause the main reason for this kind of recession in the soft tissues and the bone, and they suggested that flapless surgery should be done with immediate implantation. Of course, this was supported also in 2006, and flapless approach was advised by a lot of speakers and a lot of research papers like Bellem, just to avoid the negative effect of the extraction. So we started to do everything at that time flapless. And this case I did in 2005. And as you can see, she had a non repairable root. The patient, we did the implantation according to the protocol at that time, with a very well known implant system. And the final result, as you can see, I placed my gingival former, and the final result during the prosthetic work was satisfactory for the patient. As you can see, a good crown. I had a good technician who made a good porcelain crown, porcelain fused to metal crown at that time. But if we take a good look at the case, we can see a very severe discrepancy, and we can see severe recession in the soft tissues and the bone. And I was lucky, and the patient was lucky that she had a very low lip smile, which covered this area, and we have to mask this discrepancy with a pink porcelain. Of course, when I started the case, as you can see, the zenith line was not exactly at the zenith line of the other tooth. But if we compare it after I placed my prosthetic work, we can see that I had much more recession. So I started with a small curve of recession and ended with a severe curve of recession. In 2004, this patient came to me and I said that, okay, I'll do an immediate implantation, flapless, also flapless approach. And as you can see, atraumatic extraction, flapless approach. I placed my prosthetic guide, placed my implants according to the protocol. This is the healing soft tissues are very good. But when I placed my final abutment and my final prosthetic work, I discovered the existence of two ugly black triangles that were not satisfying either for me or for the patient. Well, I started to say to myself, why everything is happening with immediate implantation while we were promising ourselves with the much higher results. The only the At that time, one of the excellent articles that I read was done by the great icon Danny Boozer, who stated in 2004, and this article that I missed at that time, that any implant which is engaged to the buccal plate will definitely promote bone resorption. And the buccal part of the implant, that's why, should be away from the labial cortex with 1 or 2 millimeters at least away, not touching the labial cortex. And this was the first mentioned start of the placement of immediate implantation in the the proper three-dimensional positioning. As you can see, that Boozer stated that we have to be 2 millimeter away from the buccal plate and at least 1.5 millimeter away from the adjacent teeth. and the distance between the two implants should be 3 millimeter. Of course, there's a very interesting article done by Howie Glockman and Jonathan Dutoit in 2006, where they stated that all the concept of filling the socket with the implant in immediate implant protocols is now very well known as wholly incorrect procedure. And placing such a large diameter implant in the anterior aesthetic zone will almost certainly result in total recession of the bone as well as the soft tissues. So, what does it mean? It means that all of our techniques that we used from 2000 until 2006 are wholly neglected. Going back, so now I made a flashback to my cases. After reading all those articles, I made a flashback to my cases. Let's remember this case. So I went back to the surgery photos that I did. And as you can see here, that I can't move my mouse to show you that this implant had been placed solely in a very labial positioning, in a way that maybe if I place the implant according to the recommendations of Danny Boozer a little bit palatally, this implant may survive for a much longer time. The same happened here with this immediate case. Going back to the surgery case, it means that I should have placed my implant in a totally different position away from the labial plate in a way to avoid all the sequence of the resorptions. Another article by Danny Boozer also, when he made a total protocol for positioning the immediate implantation in the correct three-dimensional positioning in a way that the contact point should not be away from the alveolar bone of more than 5 millimeters. Of course, this is a very nice article and should be read by every implantologist to determine exactly the positioning of our implant in immediate implant placement, that we should not follow the anatomy, totally follow the anatomy of our socket, but we have to modify the placement in a way to be avoiding all the other bad sequences. Very nice article was done by Team Atlanta, David Garber, with Fonato about the most acceptable and the ideal positioning of the immediate implantation. And we can see from this slide that the ideal positioning should be away from the labial plate, and the implant should not be always in the filling the socket of our alveolar bone. Since then, since I read this article in 2006, we started to place our implants in the correct 3D positioning, where we take it away from our labial plate. Going back to evaluate my case, which I did before that you saw with the two black triangles, what was my mistakes? Why did I have this kind of complication? We have to analyze. Going back to the article that had been published by Team Atlanta combined with Team New York, David Garber, Henry Salama, Maurice Salama, and Enis Tarnow from New York, they showed that if we place our implant in the coronally alveolar, the coronal apical plane, we should place our implant not more than, we should place it as a 2 millimeter in depth according to the adjacent teeth, to the cemento-enamel junction of the adjacent teeth, in a way that the final prosthetic work, the contact point of the final prosthetic work, should not be more than 5 millimeter from the edge of the alveolar crest, in a way to maintain the dental papilla. In another article published 2010 showed that if we do our procedure flap or flapless that doesn't make so much difference. Of course, this is a controversial issue until this moment, while most of the clinicians would prefer to place it flapless, but this is not a must in more in the most of the cases. Going back to the case that I showed you, as you can see, I placed my implants somehow in a way that I would call them kissing implants, especially very near from the apical side. And I was lucky that to have a kind of space between the platforms of those implants, but still, I didn't place it in the correct positioning. Taking a very good look with an apical X-ray, this is totally a wrong positioning of my implant because the space that I had between the bone and the contact point is 7 millimeter. It's not 5 millimeter, and the distance between the two adjacent implants is only 2 millimeters. That's why I lost all this papilla. What should I have done? The the ideal placement is to keep a distance of 3 millimeter. So I had to open the space a little bit, making another positioning of my implant in a way that I have 3 millimeter, and I should have get more depth of my implant in a way that there is no more than 5 millimeter between bone and the contact point. And this is the exact positioning that we didn't know at that time before reading the new articles of, of Danny Boozers and Team Atlanta and Dennis Tarno. What did I do to solve this problem? Of course, now I cannot take out the implants. The only thing that I did is I tried to make more space between the platforms of those two adjacent implants. So I uh, totally changed all the prosthetic work. I changed the abutments. I made a switching platform. I placed a less diameter abutments and start to pray all the time to get what we call a creeping papilla. In a matter of 3 years, I had a creeping papilla, and you can see that I succeeded in achieving better result for this case. But this case was a very hard lesson for me to for the future to know how to place my implants. And as you can see here, after a follow-up of 6 years, I had a very good result with the dental papilla. I will never forget this amazing presentation from my dear friend and mentor, Dr. Maurice Salama, about the central lateral dilemma. And this lecture was done at one of the great congresses that I attended. And he recommended that time this issue of the central lateral dilemma can be solved by placing only one implant. There is no need to place two adjacent implants, especially if we don't have uh, enough space between the contralateral central and the canine, in a way that we only place one implant and a one pontic, and we will get much better result from an aesthetic point of view. In 2012, so we passed all those mistakes, and we start to do like a try and error and the corrections of my mistakes and everybody's mistakes, until we read this great article by Anis Tarno also, and Maurice Salama with David Garber and Stephen Chu about the what they call the dual zone therapeutic concept. The dual zone uh, achieves that every space should be grafted with the bone substitute material, of course, after placing the implant in the correct three-dimensional positioning, in a way that we will do to fill this gap with the bone graft substitute material. And this bone graft should be extended coronally up to the level of the soft tissues. It's not only to fill the gap of the bone, but to extend the grafting up to the level of the soft tissues in a way to support also the soft tissues and place our customized healing abutment or a customized temporization to keep this bone graft in place. And this technique showed very high success rate. And this is a comparison between if we place, this is a very nice study done by the same team about immediate implantation with the dual zone or without dual zone. And you can read this article, especially to get all the experience of how to place our implant in the correct positioning. Another article by Cardarapoli also suggested that the use of a bone substitute to fill the bone to implant gap and covering the defect, this will considerably limit the amount of the horizontal and vertical soft tissues alteration as well as the bone. So this concept is supported by literature, uh, what they call the dual zone technique, and you can see this is one of my cases, and as you can see that the bone grafting material is filling the gap up to the tissue level, and then an immediate temporization should be placed to keep all in place, and you can see the follow up of the if you look at this slide, at this photo, you can see some of the particles of the bone grafting materials are integrated into the soft tissue, and those not to be removed. Just leave them intact, and you see the final results after 5 years follow-up. You see the maintenance of all the soft tissues, and the bone are still kept intact the same way that we started from the very beginning. Next year, after the part one published paper, the part two had been also published to support that the same concept is a very reliable technique. And as you can see here, this is one of the cases of immediate implantation. The most important is to place our implants in the exact correct positioning where the most labial part of the implant will be at the same curve of the cingulum of the adjacent tooth with a space of at least 2 millimeter between the labial part of the implant and the buccal plate. So we don't need, from that point, I remember from 2000, maybe six or, two, or 2007, we never tried to use a wider diameter implant just to keep space. So we are using now narrower implants to keep the space between the implant and the buccal plate. And then we can fill all this gap with graft material. It's your graft material of choice. And then it's much better to cover with the custom healing abutment. As you can see, if you can place a temporization, a temporary crown, this as well, but this is according to the primary stability of your implant. But at least we have to place a custom healing abutment. And as you can see here, after 6 months, you can see the stability of the bone as well as the soft tissues. And this is the photo taking immediately when we placed the final crown. And this is 3 years for follow up, and you can see the full stability of our soft tissues and the bone. Now, a lot of research had done after 2012. One of them is very interesting, that is also done by Dennis Tarnot and Sarnachario, Guido. And the conclusion, they stated that placing an absorbable membrane and bone grafting material with a custom healing abutment, this will give the best aesthetic result and the stability of the bone. And we will gain in labial plate thickness. And they made this study according to the post-operative and the follow-up CBCTs taken for several years, where they stated that there is almost a 0 millimeter of bone loss at that time. Well, sorry, I had, okay. Well, Do we have always a good bone in all cases of immediate implantation? Of course not. In a lot of cases, we have already we have when we start our case, we had some kind of dental-alveolar dehiscences defects, which were classified as type 1, type 2, and type 3 sockets. And, and even type 2 sockets are differentiated in three categories, type A and B and C. So we are placing now, when we get more experience with the immediate implantation, we can be encouraged to do some kind of immediate implantation, even if we have a compromised uh, anti-alveolar socket. As we can see in this case, this is a type 2A socket, which has only less than 2 millimeter defect in the labial plate. So we can just simply place our implant in the exact correct 3D positioning. That means placing the platform of our implant 2 millimeter apical to the cemento enamel junction of the adjacent teeth. We should not go deeper because this is the exact correct positioning, and then we will do some kind of grafting around the exposed roots, just using the simple technique of the guided bone regeneration technique, placing a bone substitute bone graft material and covering with the membrane. And this is a 1 year follow-up. This is, as you can see, the zenith line almost is perfect according to what we had at that time. This is the final crown. This is a 3 year follow up, and you can see the full stability of the zenith line. So we have stable soft tissues as well as the bone. And this is a follow up, 5 years follow up. We get the same stability of the soft tissues as well as the bone. So we have stable, functional, and aesthetic result. Of course, for cases with the type 2C, which we have a total loss of the labial plate. I believe that the time that I am highly experienced in such kind of cases in immediate implantation, and I can place all my implants immediately to gain time and to give the patient the best results. This is a case, as you can see, a total loss of the labial plate where the root has to be extracted. The root was taken out atraumatically. My implant was placed according to the exact 3D positioning, which we learned from Danny Huser since 2004, as you can see here, and all the defected area has to be grafted. And I used all the grafted techniques that I knew at that time, like I made a mix with autogenous and beta-3 calcium phosphate. I covered with the PRF plug. So I gave everything that I know at that time, covered with the membrane, just to get the best result for my patient. On the delivery of the final crown, as you can see, the crown is very good from a prosthetic point of view. But if we take a look and at the final crown, we can see the discrepancy and the recession of the soft tissues as well as the bone that we had to cover with the pink porcelain. Okay, why did that happen? I am lucky that this patient also, she has a low smile lip line, and she is a friend of mine. She is an anesthesiologist that I work with in the hospital, and she was satisfied with the case. But for for my learning curve and for the learning curve for everybody, we have to discuss why did this happen. At that time, when I attended the EAO Congress in Rome, I will never forget what Anis Tarno said at that time. He said that if we have no buccal plate, we shouldn't place our implant. And he stated that no buccal plate, that means no implant. And he kept saying the same verse to everybody he meets at the Congress. So no buckle plate, no implant. And this was my mistake. I should have I shouldn't have placed my implant immediately if I didn't have a buckle plate. The all recommendations that recommended that we should make it as a delayed implantation or early implantation, which means that we do the extraction and keep the soft tissues to heal between 4 to 8 weeks. This will give, even if we have a labial plate, that the bundle bone will resolve and the soft tissues will spontaneously heal. This will provide us with at least of 3 to 5 millimeter of additional keratinized mucosa in the future implant site. So this was the point, that if we left the soft tissues to heal, not placing our implant immediately, leave the soft tissues to heal, this will give us at least a sevenfold increase of the soft tissues thickness in the midfacial region, which is extremely important for the final aesthetic result. So afterwards, I said, okay, I'm a, I'm a great surgeon. I believed in my capabilities. I was overconfident and I was following the rules. Just follow the rules and the protocols. This is another case of type 2C. After following the recommendation of Anistarno, I left the case after extraction for at least 4 weeks to heal. And this is very clear that I get a better soft tissues. This is a CBCT of the case, as you can see, and the clinical view, a typical type 2C, no bone at the labial, and I made like an early implantation. I left for 3 to 4 weeks. Then I tried to use all the techniques that I have, osseodensification, PRF, all the kinds of bone grafting, just to get the best result of this case. And look, I placed my membranes, bone grafting material, PRF, collagen membrane, and I placed a temporary prosthesis to be delivered. It was resin bonded on the adjacent teeth, and this technique will give a much better look to your soft tissues, and they will heal according exactly the way you want for your final prosthetic work. Okay, look at the final result after post-operative CBCT, and you can see very clearly the amount of bone that we gained after placing this implant. But the patient came after almost 3 years, and you can see that taking a good look, even if the prosthetic work is very good, but if we take a very good look, we can see a kind of resorption in all my graft and all the procedure that I did. I didn't get the same result that I was dreaming of. Then why? The first thing that I didn't take very good attention to at that time is the gingival biotype. As Joseph Kahn used to say, that we will definitely get a facial recession if we perform an implant with, in the case of thin biotype. So at that time, I should have taken this care, that I should have made a connective tissue graft at the same time of the immediate placement. And this is recommended by Joseph Kahn and a lot of other workers, like even Danny User, when he stated that because aesthetic complication will increase in patient with the thin periodontal phenotype. Additional surgical intervention should be necessary to enhance the surrounding soft tissues architecture. Now, a new technique has arisen 10 years ago, which is for a lot of people, it's a new technique about the assist. Oh, I'm sorry. Here, yes, this is what Howie Gluckman and Jonathan Dotwa that said that both protocols, immediate and early placement protocols in the aesthetic zone, will always require management of the soft tissues. And this is recommended now for most of the cases. You can use the technique you want, the pediculated connective tissue graft or the free gingival the connective tissue graft, the free gingival. It's up to you. And some of them would think that the pedicle flap from the palate, like my dear friend Edgar Shahar from New York University, he would recommend this kind of flap at immediately during the implant placement. This is how I corrected the case. As you can see, this is the case of immediate implantation placed. 3 years later on, she had a depression on your left side of the slide that is easily corrected just by placing a connected tissue graft, and you can see the final result on your right side that it makes a lot of difference. We should take very good care about this kind of phenotype. A new technique arose also in 2017, and it was published by the Agnini brothers, what they call surgical veneer grafting, with a cooperation with Henry Salama, Maurice Salama, and David Garber. And this technique gave an excellent results that you should do the final augmentation with the soft tissues at the same time. And we can see now the technique in details. This is a case of immediate implantation for a lateral atraumatic extraction. You can see unrepairable root, atraumatic extraction, and placing the implant in the exact three-dimensional positioning. I just raised a minimal flap just to show you how the exact positioning. This is the veneer grafting. You place your bone substitute material. This is mixed with IPRF, and we can place our final abutment with the concept of one abutment, one time. We do the overcorrection. We place all our grafting material, and you can see the stability here at your left side. 4 months when we deliver the final prosthetic work. At the right side, 1 year and a half now. This is 30 years follow up, and you can see the stability. 10 years ago, a new concept arose in the mind of Marcus Herzler, which is called the socket shield technique, which will be very beneficial in the cases of immediate implantation, just to keep the labial plate and the full contour of the soft tissues and the bone stable. Of course, it's published, since this article was published by Marcus Herzler since 2015. The concept is to leave a tooth segment, which usually it's the labial segment, that if we leave it in place, we will trick the biology of the body, so we don't get the bundle bone resorption. Other articles were also published and developed by a great mentor and a dear friend of mine, Dr. Howie Glockman, about the socket shield technique in cooperation with Maurice Salama and all the team. And this is like a brief, short summary about the technique, leaving a part of the root, which is usually the labial plate, to maintain the contour of the labial plate, and placing the implant in the correct 3D positioning. If we just follow the rules, we will be able to place our implant in the correct positioning, and then at the same time maintain the labial plate. This is the technique after a preparation of the root shield, what we call it the root shield or the socket shield, placing the implant, filling the cap with the bone graft material. And this is 4 months when we place the final prosthetic work. You can see on your right side follow-up of the case on the CBCT, 12 months and 3 years, and you can encounter the full stability of the case. This is a 5 years follow-up. All the soft tissues are maintained, and the bone is also maintained. So it's a very reliable technique, and a special kit was uh, produced for that, and I was happy to get one of the prototypes of those kits by my dear friend Howie Glockman. And I promise you that after 10 years of a clinical study that had been made by a special team for the partial extraction therapy team, they stated that after 10 years, they got great success. This is another case, socket shield technique on 4 implants, one abutment at one time, bone grafting material, and placing a temporary prosthetic work to, to give the contour of the soft tissues. This is a 1 year follow up, and you can see here a 3 year follow up. All the soft tissues and the bone was totally maintained over the years. This is a very promising technique. Of course, now it's not only promising, a lot of clinical study, histologic studies had been done that proves 100% the success of this technique just if we follow the rules. And this is was published in several articles since 2016 until now, and the special team all around the world was gathered together to get multi-center clinical studies that is under the umbrella of Dental XP with great clinicians around the world. They gave a 10 years study, and it was published last year. To summarize my presentation, that I would say that during those years since the early placement of the implants until now, immediate implantation went through several stages, and those stages were through the years improvement in the how do we understand the our complications and the corrections of those complications during those years. And as we go on with our learning curve and we read more research, we can realize that a lot of the complications that we think that they were complications at those years were really a series of mistakes that we did according to our knowledge in that cases. So we have to keep up. We have to keep up to read new techniques and to follow up all the research. As we know that the immediate implant placement are one of the most technique sensitive with the very high risk of complications. That's why dramatic changes had taken place during those years, the concept, techniques, and the guidelines. And those guidelines were changing all over those years, year after year, with more research and papers that were done. So as we climb up with our learning curve, we will be more able to define a new cutting edge in our understanding of those complications and failures, which were actually some mistakes that we did unintentionally. That's why I call a complication of yesterday is a mistake of today. We shouldn't repeat it as per the new update guidelines. My take home message for you after this that the first step is to have we should make a revision to our cases. We have to confess of our complications and mistakes, and we had to develop a revised, more beneficial plan to implement in the future. So we climb on a solid base for increasing our knowledge. This is done only by attending conferences, taking courses. I know that now I'm with you live now on Facebook and YouTube and so on. But please, 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 for all the colleagues, I would always say that Facebook and YouTube are informative. They are not educational. We shouldn't go to learn a new technique just by clicking on YouTube and see somebody is doing this technique. For every case, we have to read more, we have to take courses, and we should implement a real beneficial plan in the future to do this correction. We all do mistakes, but we have to be, to correct those mistakes, because mistakes and correction, this is the real learning. The most important is we should never repeat those mistakes. With this nice view from my place in Tartus, I would like to say thank you all for your kind attention, and hopefully we meet again and again in other conferences. And I'm ready to answer any question through. You can send me emails. You can follow me on Facebook. You can follow me on my website. I'm ready to answer everything. And thank you for hosting me.
Thank you very much, Dr. Imad, for your nice presentation. Scientific outstanding as usual. يعني I mean that fantastic review with 20 years. It's good to reflect how the work should be professional and documented. I will check if any colleague has a question from the comments. They all say thank you, Dr. Imad, for your amazing presentation with these nice cases. So I think there is no questions right
There are no
now.
specific questions.
No, no. They all just
Okay, that's
say
great.
words of thanks. So
That
I
means
think
everything was clear. Thank
yes,
you so much.
everything was clear, and most of them note that the cases explained many things that maybe uh, they should to know. Thank you very much again, Dr. Imad.
Thank you for your
Uh,
hosting, and hope to see you all again soon.
Looking forward to seeing you soon, inshallah. Thank you. Have a nice.
Hopefully, live in Libya.
Yes, inshallah, in person soon with some courses, maybe in bone graft, in advanced things, inshallah,
It
Dr.
will be a
Imad.
pleasure. It will be a
You
pleasure.
are
Thank
more
you.
than welcome in your country in Libya. Thank
Thank
you
you.
very
Thank
much.
you. Thank
Bye
you
bye.
all.
Bye bye.
Bye bye. Have a nice day.
You too. And now it is the time to say welcome to our colleague from KSA, Kingdom of Saudi Arabia. He is Dr. Abdulaziz Al Ghafari. He is our guest for the first time. Um, I really showed many cases for Dr. Abdulaziz on Facebook and another social media, and it was very interesting to know many things, especially in the topic 3D printed implant solution. So welcome Dr. Abdulaziz for our third day of MDM, Mediterranean Dental Meeting. I can't hear you right now, Dr. Abdulaziz. Maybe you should check your mic or your headset. No, I think yes. Now I think you can talk without headset if there is any problem, technical problem. Yes, just unmute please from your side. Just unmute your mic. Yes.
Okay. How's
Yes,
things
now
now?
it's okay. Please come
Very
back
good, thank you.
to the presentation. Okay, the screen is yours, Dr. Abdulaziz.
How it
Welcome
looks now?
again.
Okay, thank you very much, Dr. Ali, and I'd like to welcome everybody in this sessions. Yes, it's my first time actually to give this, I call it an ideas, a lecture that contain ideas about new technology that me as a clinician was so not unhappy practicing implants since 2000. I graduated from USA Marquette University, And during that time, I saw a lot of cases, what you call it, starting early in the implant dentistry. But I also saw during my residency programs and certification programs, I saw a lot of cases that was not explained to me in reality why they need it, especially for the severely atrophied arches, which sometimes we stay uh, we cannot solve those things. So also I went to some uh, exhibition talking about 3D printing, and I found not that much people talking about what's happening in this dentistry or in the medical field itself. So I thought probably it's our duties as dentals, we should explore those things and look for solution for our patient that could not have any solutions. So I think now, as this statement, that 3D printing is playing a big role in the medical field. And we, as a dentist, should be part of this, what do you call it, innovations in any way. One of the most innovations that we need to be part of it is the medical device. Patient come to your clinic, they need solution, cannot be offered into the existing technology or existing techniques for so many reasons. And we saw, all of us, we saw cases, we just simply tell the patient, sorry, my friend, or sorry, my patient, we have no solutions. I am coming from an area where patient, uh, they don't like to have, what do you call it, a partial denture or complete denture. They want to have uh, fixed dentures or a fixed prosthesis in their mouth. And sometimes for severely atrophied ridge, we cannot have the solutions. So I would like also to share with you, I'm talking here and I'm bringing some slides and some cases through a company called Bonizi. For clarity and clarifying this, I'm part of these groups in all the field in researching and developing, and also in trying to give the solution to the market. I just want to, as a medical device, show you what do you mean by giving such solutions, if you allow me, please. So coming back, so what I show you, because actually I was so unhappy sometimes. I couldn't find solution in the market. So when I will tell you the story how I met Roy and we start talking about this solution. I just want to give a highlight in what's happening now in the medical device regarding different type between 3D bioprinting and 3D bioprinting type prototyping. A 3D bioprinting that we are printing either cells or growth factors, whatever. But for us in dentistry, the biocompatible materials is a very important, and some of those materials can be titanium or PEEK or hydroxyapatite or whatever, or polymers are very important for our solutions. Uh, the bioprinting is almost like what the dental technician is doing in their lab. They are doing 3D printing for something. They will try it and then they will process it in their own way according to what they need. Giving high to those bioprinting, what we start to see now in the medical field regarding which printer that we need, how's the accuracy, and all these factors are developing. And we reach in our dentistry, we reach to different type of printer that allow us to do those things. And we should differentiate between the printer that we use it in our laboratories, or the printer that we should use it in the medical device. And for so many of us, we some of us does not differentiate between what you call a lab product, which is a routinely lab products in their lab. They can do it by 3D printing, or what you call it other medical device, which should be done in a different way. And those are the type also of 3D printers in the market regarding with specialty. And if you see for dentistry in the lab or things, we are in the SLA or DLP or LSCD in the small lab and small machine. And in the selective laser ones, for example, metal, titanium, or things, uh, those are the type using in also in the medical devices procedures. So just fuse deposition molding, use simple material as polymer or filaments to, for example, printings, skull or printing of jaw models. Also SLA and DLP and LCD, they can do that also for these things. As I said, the SLM part of where we can selectively laser melt material, and especially for us now, titanium grade with a different grade for the medical devices. We started also now to print other material like ceramics or polymers, and especially now the calcium hydroxide and the peak aluminum oxide also, sorry, the aluminum oxide and zirconia also is coming. Some of the polymers also we are start, especially in creating some guides and also in creating some surgical guides in regard scavengers to guide the bone regenerations. One of the problems that we have from different material is the biocompatibility or the resistance, like what's happening now. Zirconia is becoming very attractive. It's a very, biocompatibility is not like the hydroxyapatite, for example, or aluminum, but it's a very resistant material that we can use it in our procedures. So ceramic, one of its problems is the changing in dimensions that we should take care if it's related which type of printing that we should use or indications. We see now increasing in those types, especially peak materials in regarding defects, especially in the craniofacial defects, and also in small area defects, or also in increasing aesthetics sometimes, or changing the profile for the patients. As we said, polymers, it's part of the things are coming also and can be used also for this technology. This is where our interest now is coming. We're starting printing metals, and when we talk about metals in medical devices, we're talking about titanium, for example, grade 5 or grade 23. And titanium is